Hi, my name is Dr. Atiya Mosam. I am a public health medicine specialist and I work at PRICELESS SA at the University of Witwatersrand. PRICELESS is a research to policy unit and most of our work relates to decision making and priority setting in the South African sector. It encompasses both health economics as well as decision science, and I'll speak more about that as we go. My role specifically is as a senior researcher. I am involved in a few research projects as well as overseeing some of the research that we're doing. So access to healthcare, I think many people think around access as being physical facilities that they can go to. That is just sort of one aspect of access. So yes, it is about having facilities that are, geographically close to people that they can access, either by walking or a relatively quick transport ride, maybe one taxi away. I think aside from geographical access, there is the affordability aspect of access. So we know that in South Africa, at point of service, services are free, so at primary healthcare level, and then at a hospital it is according to your income where you pay on a scale. But there are costs that patients have to pay in order to even get to the facility. So transport costs, the unseen cost of missing a day of work, especially if you're not in a salaried position, and then also costs related to maybe food during that day, costs related to finding a babysitter if you need it. So that is one of the aspects of access that people don't really think about. And then the third is part of access that needs to be also taken into account is acceptability of the service. So it's fine if someone can get to it, they have the money, and there is something near to them. But if the service is not acceptable, if staff are maybe rude to them, if there's a really long waiting time, if the facilities are not clean, that is a part of access that might also deter patients from accessing the service. So when we think of access, we really think around whether there's geographical facilities available, can people afford not just the service at the point of service, but getting to the service, and also when they get to the service, is it acceptable for them to use that service? Okay, so we're talking about health as a human right, and it's enshrined in our constitution, and it's also recognized in the NHI as a right to South Africans, and that is part of what the NHI is doing to move us towards universal health coverage. So universal health coverage is ensuring that people get the range of services that they need at no cost to them, so you shouldn't need to be financially liable for those services, and in a quality that is amenable for patients. So what PRICELESS does is so there's many units that do research around health care as a human right, and it might be in a range of areas. So some people might be looking at what the burden of disease is, so that they can inform where policymakers should be putting interventions in. There's other units who might be looking at what patients actually want or what patients think. PRICELESS looks at helping government or policymakers to put in place their policies, but from a perspective of how to make the right decisions. So the two arms that they utilize one is the health economics arm, where they look really at the economic decisions that government can make, and that is looking at, for example, using a cost-effectiveness analysis to look at how cost-effective an intervention is. So taking into account what the cost is versus the benefit, and according to the gold standard or what is currently the care, should an intervention be employed or not. They help them to prioritize risk groups. So for example, looking economically, if we had X amount of vaccines for the flu, who would the priority groups be? And similarly, we use that type of information. You can see now with COVID, not that PRICELESS is specifically doing that work, but that's the type of information that government needs, is in a resource constrained setting, how do we prioritize people? So the economic arm of PRICELESS looks a lot at that type of work. And then the priority setting or the decision science arm looks at more around, what are some of the tools that government can use to make better decisions. So one is a tool that has been developed by some of the team called Choosing Health Altogether, where they've got a process of helping communities to think through what are their priorities for health, so that they are involved in decision making around their health. One of the other big projects that Priceless is undertaking, which sort of marries the health economic stream with the priority setting and decision science stream, is something called SAVE-UHC, which stands for South African Values and Ethics for Universal Health Coverage. And what this project is aiming to do is to look at the set of ethical values as enshrined in our constitution, as we know in general medical terms to be, ethical values that are pertinent to patient care, and looking at how that augments decision making, specifically in the context of health technology assessment. So just a little bit about health technology assessment. That is a process of looking at health technology, and the word technology is slightly a misnomer. I know people's minds immediately go to smartphones or CT scans, but it's looking at a range of interventions. So it could be vaccines, it could be a prevention program, and through a systematic way, looking at the various components of that intervention and then deciding whether the country should adopt it. So usually what people end up doing is they look mostly around the economics and the health condition. So they'll say, is this a big burden on our country? In our setting, can we afford it? And then, they decide whether to roll it out. Technically, what health technology assessment should include is looking at these ethical values and some of the rights of patients and of the population. So we look at things such as equity, which is a bit broader than pure economics and disease burden. So for example, if we look at giving a vaccine out, is there an unintended consequence of giving the vaccine out where maybe people from rural areas or from lower socioeconomic status populations might not be able to access the vaccine? Because as I spoke to you earlier about access, it's not only about having the vaccine available, it's having those people being able to access it via maybe affordability. So when we are looking at the SAVE-UHC process, we're looking at dimensions such as equity, such as personal safety. Is there a way that someone's safety might be compromised by virtue of the fact that this intervention is put into place? Whether it's safety of the healthcare worker, by us sending them maybe out into the community, or the safety of the patient. We look at aspects such as social cohesion. Would putting an intervention cause a problem for society as a whole? So, for example, if we were to give a medication to people who are addicted to certain substances, would the community see that as enabling and therefore cause problems within the community? So these are some of the sort of broader issues that societies or governments and policymakers need to grapple with when they think through an intervention. Sometimes it's not done in a very systematic manner. It comes up maybe naturally, but it's not always considered. And so what we're looking at in the SAVE-UHC process is there a framework, and we've developed a framework with South African stakeholders so that it's a South African specific framework. Is there a framework that we use that would change the way decisions are made? And if it does, how does it change the way decisions are made? So the SAVE-UHC process really encapsulates all of Priceless's work, and we are taking the economic evaluations that we've been doing to inform the case studies, and then taking into account, what society needs, what patients want, what the population thinks, and really using that to see if we can find a way to augment decision making for government and for policymakers, so that we do reach all of those principles that are enshrined in our constitution, such as equity and the right to health, etc.